Señora Presidenta, queridos amigos, perdón por no hablar en español. So I will speak English. Sorry for that. I propose to discuss with you during this half hour about the future of our profession. And the challenge obviously is great because child and adolescent psychiatry is likely to be in the health and in the health of our kids perhaps the biggest challenge of this century. Of course, you will say we are neurologists or child and adolescent psychiatrists or psychologists, and so we are always interested in kids and we always believe that we have the truth. So is it really true what I say? The answer is yes, we have data for that. These are the latest data of WHO about the disability adjusted life years that have been lost by kids from 5 to 14 years. And you can see that in America and in Europe, mental disorders are in the second position. Nutritional disorders are in the first position. And it is very likely that in the next decades, nutritional disorder will lose in importance. This is already the case in Occidental Europe. And mental disorder will be the first rank of burden of disease for kids. So these are data. And so this is our responsibility to deal with this issue for the future. So we have to come back to basics about our day-to-day jobs, that is kids. What is a kid? Obviously, there is at the beginning a pregnancy. And after you have parents, and you have school, and you have the society. And these are simple words, but society is something very complex. In society, there is culture, the religion, and you know that religion is associated to psychopathology. In suicide, addiction, religion can be a protective factor. Society can lead to stigma, and you know that in child and adolescent psychiatry, stigma is a huge problem. And society can lead to war or to violence, and war and violence in general are major risk factors for mental disorder. The problem is that, and we have also biology, we have genes, epigenetics, etc. And the problem is that everything interacts with everything. And so this is a real mess on a scientific point of view. This is so a mess that it is impossible to have a unique theoretical framework from genes to religions, obviously. And so this is very difficult for scientists to have the global picture. Anyway, this is our job. So we have to deal with that every day, and this is our job. And so most often we have to realize that things are quite fine with our adolescents and youth. You know, in your country, in my country, in most countries, children and adolescents are fine. This is good news. You know, obviously, many times we forget that youth are fine in our society. But not every youth, of course, not everyone. And some of them do not succeed in having a good mental health. Mental health, in the definition of WHO, you know the definition of mental health for WHO, it is well-being. Very close to the definition of health, but this is another topic. So most kids developed and become happy with a good well-being in their life, and this is fine. So where is psychiatry in this? What is psychiatry? Psychiatry, it is with doctors. Psychiatrists are doctors. In all countries in the planet, psychiatrists are doctors. In psychiatry, you have institutions, different institutions, from general practitioner to hospital. You have private practice and you have public practice. You have some practitioners that work alone, Many private practitioners work alone, and some others who work in a team. And in this team, there is a hierarchy. You know, this is a taboo often, but between psychiatrists, psychologists, social worker, nurse, speech therapist, etc., there is a hierarchy, and sometimes it makes some tensions between professionals. That's life. And there is research, of course, and because psychiatry belongs to medicine, most of research are done in hard science, in biology, in neuroscience for psychiatry. And of course, there is a question of money in all countries on the planet. From where do come the money for health and for psychiatry? And it depends on the country. There are many, many systems. So, what happens? Now, what is the link between the left and the right of this picture? The link is that from time to time, there is a rupture between development and well-being and mental health. There is a rupture. For instance, if you had a kid with panic attack, 1 month before he was fine, 1 month after, there is a level of anxiety that makes that it is a disaster. And this is the case for most of psychiatric disorder. Anorexia nervosa, it can be the same. Depression, why not? And even neurodevelopmental disorder like autism, you know, at the very beginning of autism, parents are most often quite cool with the baby, and one day, perhaps my baby is not so normal, and one day, no, this is no more possible. There is a real problem. This is a phenomenological rupture in the development of the kid, on how it is perceived, he or she is perceived. And at that time, what do parents? They go to see a physician, because this is what people do when they are in rupture about their health. They go to see a physician. And when it is a rupture about behaviors or emotions, the physician is a psychiatrist, and this is our job to deal with this issue. And most often, we propose treatment, and we have to take into account that the kid is going to come back to the society. And so we have to interact with a teacher, with parents, even with priest or imam in some country. No problem with that. If we want that things work, we have to interact with society. And there is something like a circle between society, development, psychiatry, and at a given moment, it works. There is a cure. The patient is fine. And most often, people do not know that in society. Most often, our patients are cured one day. Of course, there can be relapse in schizophrenia, in anorexia nervosa. There can be relapse, but there can most often patients are cured at least for an important amount of time. So this is our job, and this is how it works. Unfortunately, from time to time, we cannot achieve cure. For instance, in autism, in severe situation of autism, this is not possible. And so, it is not possible that the kid come back within the society in normal school with his friends. The level, the burden of the disease is so important that the society cannot accept him or her like he or she is. And here there is a role of what is called special education, medical, social institution, psychosocial institution. It depends on the country. There are very different words, but these institutions do exist in all countries. Special education, when it is not more possible for the kids to come back within the society. And of course, there is a necessity to have a relationship between psychiatry and special education, and in most countries, this is not so easy at all. There are tensions between both institutions for many reasons, reasons of power, history, culture, etc. And this will be, of course, a goal for the future to make that all these things work all together. Anyway, so this was a picture of what we are doing every day. So how should we do to plan for the future. First, we have seen that there are two different things. One is about mental health, well-being. The other is psychiatry, which belongs to medicine, and these are two different things. What about the future of mental health? First, societies have to evolve and to adapt themselves. Why? Because we don't realize that today our societies are experiencing incredible change. Incredible change. For instance, the structure of family is changing in nearly all countries of the planet. The level of divorce is increasing a lot, and you know that divorce has an impact on the well-being of kids. Many studies about that. There is a split between generations, because adolescents and kids are on Facebook, look at pornographic films, and this makes a tension with the adults that don't know at all what is Facebook, what are social media, what is this new way to interact between people, you know. And this raises problem of communication between adults and youth. I'm sure that you experience that every day in your consultation. Another thing is because everybody can have an access to all the literature on psychopathology, we have now a huge source of knowledge that we have to know to improve our day-to-day practice. We have to read an international literature, scientific literature, but we also live in our own country with our own culture and roots, and we have to make a balance between local specificities and global knowledge, and this is tricky. And in addition, you have now the question of difference. You know that many patients with autism or ADHD consider that they have no disease, they are just different. They are different like some minorities, and they have to be acknowledged like different people, not like patients. This is a real issue for the future, because in a way, they are right to say that. So, in practice, what should we do? First, we have to fight against violence, because violence is the main evitable risk factor of psychopathology. And you surely know that in most countries, where is violence? Violence is within the family, between the parents and the kid, and between the parents themselves. And so, and many bodies in society do not want to see that. This is a taboo. And we have to struggle against this taboo. We have to increase the level of parenting support. We have to train teachers, because kids spend 6 hours a day in most countries in school. Sometimes they spend a longer duration with kids than the parents themselves. And teachers are experienced with kids, and they are likely to screen problems very early, and this can lead to early intervention that are very efficient. And we have to think global and local, and this is, on an intellectual point of view, very tricky, because change are global because of the globalization, and culture is local and very strong. We completely underestimate the importance of culture in our societies, because we believe that we are all connected, that culture has disappeared. This is completely false. Culture do exist and structure societies and human beings. Now, this was for mental health. For psychiatry, it is now acknowledged that a healthcare system has to be organized with lines, first, second, third lines. The first line concerns primary care actors, those people that are in the first contact with the kids. General practitioner, school nurse. In most countries, general practitioners do not learn child and adolescent psychiatry. They know very well otitis, and they don't know ADHD, while the burden of disease of ADHD is much more important than the burden of disease of otitis. So we have to change how we teach pediatrics in medical schools. Then you have the second line of treatment, which correspond to small specialized local units, multidisciplinary team, social worker, nurse, psychologist, counseling, of course psychological treatment, psychiatrist, not always, because some countries cannot provide enough psychiatrists in order to be available in these small specialized local units. You know, in India, for instance, there is more than 1 billion of inhabitants, and there are only 60 child and adolescent psychiatrists. 60 for 1 billion of inhabitants. So you cannot imagine that there is one child and adolescent psychiatrist per specialized local units. This is not a problem. You have to deal with the resource you have. And of course, you have to maintain close relations with local actors, parents, school, primary care, etc. And you have always to have in mind that you can do only what is sustainable. When you read papers, you can see that some evidence-based medicine treatment require 3 sessions of psychological treatment per week during 3 months. This is fantastic, but I know only a couple of countries in which it is possible. So even if it is evidence-based, this is useless. And after, you have the third line of treatment. At a regional level, specialized unit, of course, with high-level evidence-based specialized treatment. Links have to be kept with second and first line treatment. They have also to answer the question, who should we treat? Because all patients cannot go in a third line treatment, and they have the responsibility to do research. As I told you before, there is a special situation about chronicity, like in autism, and with chronicity we have to take into account the question of special education, and it will depend on the country. And in this area we lack some kind of evidence-based data. And this is a real problem. In psychiatry, we impose evidence-based treatment. In special education, the level of evidence-based education is much lower, and we have to do research also there. The keywords about that are very different than in medicine. You have the notion of disability, empowerment, inclusion, very specific concept. And there is also the question of transition to adult psychiatry. And you know that in autism, the transition between child and adolescent psychiatry and adult psychiatry in most countries is not a real success. Special education have to change also, not only psychiatry. You know, in many countries, special education is done in institution. And so it induces a stigmatization and a marginalization of patients. And now in some countries, they think about special education within normal education for all patients. This is very ambitious, but I do think that this is a good direction to follow. After, we have also to plan departments specialized in very young kids and adolescents, because the clinic is not the same. We have to think a balance also between public and private practice. Here again, because there is money behind, this is a taboo, but this is a reality. What will be the obstacle? The obstacle, the first one is the curse of care, you know. Most of our treatment, the basis of treatment in child and adolescent psychiatry is care. Psychological treatment are a very sophisticated form of care. And unfortunately, many people consider that, well, because this is care, this is valueless. This is something for women. And women naturally deal with kids, and that's life. We don't have to spend money with that, which is completely crazy, because we all know this is not reality. The ambivalence toward kids and adolescents. Everybody considers that everybody loves kids and adolescents, and so this should be a priority for public health. But in fact, you know And there are many good papers about that. Just when you take a plane and when you see a baby coming into the plane, you pray that the baby will not sit very close to you, I'm sure. And so, in fact, we don't like babies that much. And we don't like adolescents that much, neither. Even us. So imagine in the general population. Anti-psychiatry exists in all countries. This is an old story, you know. This is just psychiatrists who have created a psychiatric disorder. And this is very difficult to struggle against that. Neuroscience has been very good to struggle against anti-psychiatry, because with neuroscience, with brain imaging, you can see the disease. Bad practice. This is our responsibility. There is corporatism in many situations, and this corporatism breaks the progress. Clinical ideologies, you know, this is a very old story. 30 years ago, psychoanalysis was some kind of religion, and it was crazy. And nowadays, in some country, neuroscience has become a new kind of religion, and this is crazy in the same way. There, as I told you before, you cannot have only one theoretical framework to go from genes to religion. We have to accept multiple theories. Overuse of medication, this is a real risk, you know. In some very big and developed countries, about 10% of kids, of boys aged 10, take stimulants for ADHD. 10% of kids aged 10. This is crazy. This is not a treatment for ADHD. These are cognitive enhancers for most of these patients. And I do believe that in 10, 20, 30 years, we will be accused to have done a very big mistake about that. The prevalence of ADHD that should be treated can be 1, 2, 3%, not 10%. Now, my conclusion. First, we have to notice that society are experiencing colossal tension. We have to adapt. And many times people ask to psychiatrists, how should we deal with this change in societies, especially child and adolescent psychiatrists? They go in front of the TV, in the radio, and journalists ask, what should we do? But we have the duty to say, you ask me the question, but this is not my job to answer this question. My job is to treat patients. My job is not to tell the truth about the future, about political decision. I can give an advice with humility, but not to say what should be the politics for the next century. Indeed, child and adolescent psychiatry is likely to become one of the main medical specialties of the 21st century. And how can we deal with that? We have to consider that it is a medical specialty. We have not to have any complex with that. Many child and adolescent psychiatrists often say, we have no mental disease, we have only mental disorder, we are different. No, we are not different, we are medical specialty. Mental diseases do exist. Anorexia nervosa is a mental disease. And that, like the prognosis of anorexia nervosa is the same of a skin disease. So these are very serious diseases, like all other diseases, and this is reality. This is not because it is a psychiatric disease that it is a so different disease. Of course, we have to use evidence-based treatment, but they have to be sustainable and transposable to the local culture, and this is the only way to have ethical treatments. We have to take responsibilities about who should be screened and treated. This is not a funny job to do, because this leads to say, these kids, we shouldn't treat them. And we are not at ease to say that. But if there are only a limited amount of resource, we have to take this responsibility. We have also to answer to the question, who does what? Psychiatrists cannot do everything. We have to train during all our life, and we have to do research, because there are so many things to find. And this is my last slide. We are not alone. now there are many other areas. The notion of mental health, the notion of mental disability are emerging, and we have to work together. Even if we are not very pleased with that, this is reality of societies, and we have to go hand in hand. And we have to know that this is not easy, but we have to do that. We have to remember that there are multiple levels of intervention, a hierarchy of intervention, the global society, parenting support, primary care, second line, third line, and we have to think in terms of age, special education, public-private practice, and at the very end, we have to remember that we need money. And so we have to look and to find our politician and to say, you give money to cancer, to Alzheimer's disease, you have also to remember that child and adolescent psychiatric disease are going to be the main source of burden of disease in our country. This is your responsibility, politician, to found treatment in this area. And I thank you for your attention.